So I got a ton of email questions and some Facebook questions and a few other questions. So I'm going to go ahead and read them off as they go, because a lot of you had the same, very similar questions. So the first question I got, the most popular one, says, my doctor has prescribed oxygen for me at 2 liters per minute. Do I need to use this 24 hours a day, 7 days a week? So the answer is it depends on what your doctor told you, and it depends on what kind of testing that you had. So Rick, feel free to chime in if you have any insights into this. If your doctor said you need 2 liters of oxygen, he probably told you you need it maybe just with exercise, or you need it around the clock, or you need it just at rest. Usually if you need oxygen at night, they will do something called an overnight oximetry test. So that's where you take a pulse oximeter home, and you put the little probe on your finger and you go to sleep, and when you wake up, you take the pulse oximeter back to the hospital. They download the overnight data to see if you desaturated overnight, and if you did, then you'll need oxygen overnight. So I don't know how many of you have had that test. If you remember having that test and your doctor said you need 2 liters, then I'm going to guess probably overnight and 24 hours a day. But your best bet, of course, is go back to your doctor and ask exactly when I'm supposed to use this. Day, night, exertion, sitting, all the time. What's the story? And on that note, I just want to add that oxygen is very, very important. I see a lot of people use it wrong. I see a lot of people sit with their oxygen on while they're reading, and then as soon as they get up to go do something, they take it off. And that's probably the exact opposite of what you need to do. At rest, you're probably breathing quietly, but as soon as you start exerting yourself doing something, that's when you need it. And I know it's a pain to drag behind you and take with you everywhere you go, but that's how you protect your heart. So I'm going to ask you, if you've been prescribed oxygen, to please follow direction and use it. Rick, did you want to add anything to that? I'm going to go on to the next question that came in, and that was, my insurance changed me from Advair and Spiriva to steel toe and Arnuity, and I'm told it's the same. Is it the same? It's the same base drug. It's the same generic formulation. They're just different companies with different propellants in them, or different delivery systems, and made by a different company in a different format. But essentially it's the same. But I've had people tell me, when I was on Advair and Spiriva, I was doing great. Now I'm on the steel toe and Arnuity, and I'm not doing so great. It's not the same. So the best thing I can tell you is, if you don't feel the same, if you get your drugs switched because of your insurance or whatever reason, and you don't feel better on those drugs, and you feel worse, then you need to go back to your doctor and say, this isn't doing it for me. I want to go back on what was working for me. You may have to put up a bit of a fight with your insurance companies. You may have to put up a bit of a fight just to get what works for you. But again, they're the same general formulation, just different propellants, different delivery systems. So be your own advocate, be your own best advocate, and fight for what works for you. That's the most important thing. Okay, any other questions? You can put them in the chat box. Any comments from anybody? I'm going to try my best to do 3 things at once here. Okay, next question that came in says, my home routine is Advair in the morning and in the evening, Spiriva at noon, and my ProAir that I use whenever I need it. When I was at the hospital, they gave me my Advair and my Spiriva together, and then albuterol only if I asked for it. So what's the deal with that? What's the order that I should take them? Is this okay? So the order of taking your medications is a very tricky thing, a very personal thing. Most people will do Advair first, let that sit on the lungs for 10-15 minutes, then do your Spiriva or its equivalent, and let that sit, and then Advair 12 hours from the first time, and then their ProAir or whatever your albuterol is every 4 hours in between if you need it. Some people have a very busy lifestyle, and they go, you know what, I'm going to do my Advair and Spiriva together and my ProAir right after that. The answer is it really depends on you. You just got to play around with it a little bit. You've got to figure out, can I take them all three together? Do I feel just as good if I take one, wait 10 minutes, let it sit on the airways, take another one, wait 10 minutes, let it sit on the airways, take another one 10 minutes after that. So it's really individual. You've got to really decide what works for you. There's kind of no wrong way to do it. Old school was we had to do the albuterol or its equivalent first, and then the Spiriva, and then any kind of a cortisone, inhaled cortisone after that. And so again, we found that just by changing it up a little for you, just keep track of what you do for yourself and figure out what's the best routine for you, what really, really is going to work for you. So I hope that helped. And let's go on to the next question that came in. It says, every time I go to the doctors or to the hospital, they put a pulse oximeter on my finger. Should I buy one? That really depends on several things. If you're exercising and you're on oxygen, I would say yes. The reason being, the short answer being, the more you exercise, the more you're going to be able to do. And the more you're going to be able to do, the more you need to make sure you're oxygenated enough. So in that instance, I would say yes. If you're not doing much exercise, probably not. The thing about pulse oximeters, you can buy a cheapy $40 one at Walgreens or online or wherever. They're all pretty much made in the same place. Most of them come from China, so they're all roughly accurate in terms of they may be 1 or 2% off. And the thing about pulse oximeters is if you're 1 or 2% off on the upper end of the scale, that's not a big deal. But at the lower end of the scale, you can really be very far off. So if you're one of these people that routinely exercises and you let yourself get down to 82%, that 82 is probably really more like 70 something. But if you're keeping your oxygen up and your pursed lip breathing and so forth, and your saturations are 93, and then you try another pulse oximeter and it's 94, that's no big deal. You're on the upper end of the curve, as we call it, which is a good thing. Once you get below 92%, you're kind of hitting a slippery slope of trouble, and you don't want to do that. Even if you stop exercising when you hit 88%, your heart still continues to beat really fast. You continue to need oxygen for the next couple of minutes while you recover, and you really are desaturating a little bit more before you ever recover your saturation. So just be careful of that. And another question that just came in, it says, I often wake up in the middle of the night with shortness of breath. What is this? Well, it could be a whole lot of things. Oftentimes when I have patients tell me that, I do a little bit of discovering. What I find out is that a lot of patients with COPD cannot breathe well lying flat. You may have discovered this and you're probably already propping yourself up on a ton of pillows. But what will happen is somebody will take their Advair or their albuterol or whatever you're taking right before bed. So you lie down to go to sleep and you're okay lying flat or with one pillow, but 4 hours later when the albuterol wears off, all of a sudden you wake up in a panic because you can't breathe. So really try to set up your sleeping station, whatever it is, so that you're sitting a little bit more upright. That allows the diaphragm to drop further and allows you to get a better breath in. I know it takes a minute to get used to doing that, but that might help you sleep through the night. And then I got another question that just popped in. So what happens, what's a good thing to do when you suddenly wake up, or even in the middle of the day, sometimes that sudden panic feeling like suddenly that short of breath comes on? So a couple of things. If you have really a sudden onset of shortness of breath that doesn't go away with some standard techniques that I'm going to show you in a minute, go get seen, because it could be something a lot more than just an exacerbation coming on. It could be a pulmonary embolism. It could be all kinds of things. So if you can't help yourself in about 1 minute, and it's a sudden onset of shortness of breath, definitely go see somebody about that. If you've been slowly, gradually getting more and more short of breath and suddenly you realize, wow, this is really getting me, try your pursed lip breathing techniques. Whatever it is you're doing, stop. First of all, stop, get yourself to sit down or stand up and and support yourself on a table with your arms so that you can really spread your ribs and get a good deep breath in, and just practice your pursed lip and diaphragmatic breathing. And if you've never been to pulmonary rehab and didn't learn that, it's just in through the nose and out through pursed lips. And you're going to keep blowing all that stale air out until you get every last bit of it out. Not pushing, not passing out, just completely exhaling. And then a nice slow deep breath in. And you can kind of do a little mantra while you're doing that as you're breathing in through your nose, saying, I'm breathing in, I'm breathing out, I'm breathing in, I'm breathing out. And again, if you can't break the cycle of that feeling of shortness of breath in about 1 or 2 minutes, then you may have something else going on and you may need to go get seen by somebody. Call somebody, head to the hospital, call your pulmonary doctor or clinic. Very important that you get seen if you can't relieve that shortness of breath. All right. A couple more questions popping up. This is great. One of them, let's see. How does what I eat affect my breathing? That's a great question. So a couple of things go on. If you're accustomed to eating 3 big meals a day, then when you eat a lot, your stomach pushes up on your diaphragm. So you got that big steak dinner in there pushing up on your diaphragm. So that limits your ability to take a deep breath. So a lot of times that will hinder your breathing. Another thing that happens is a lot of people who learn not to eat great big meals will eat several small meals a day, but those are really carb heavy. People just kind of snack all day. It's very carb heavy, so you're not fueling yourself very well. You've got nothing but carbohydrates in you, which turns to sugar, which contributes to your carbon dioxide. So do your best to eat small meals, maybe 5 or 6 small meals a day, but make sure they're balanced. They're not too carb heavy. You're getting your proteins, you're getting a little bit of good fats like avocado and olive oil, and you're getting enough calcium with dairy products if you can do dairy. All righty, next question that came in, because my doctor sent me to do pulmonary rehab. Never heard of it. Oh, wait, I've got an answer back from Rick, Rick is our other respiratory therapist on the line, by the way, but he doesn't have a microphone, so he can only type in. So he says, red and green vegetables have xanthines, which promote airway dilation. Good choice. Yep, red and green vegetables. All vegetables are good for you, but the reds and the greens have xanthines. The other thing that has xanthine is coffee and tea. The caffeine in coffee and tea. So I don't recommend running out to Starbucks, but if you get yourself in a fix and you're really, really short of breath, making yourself a strong cup of coffee or tea does have methylxanthines that'll help dilate the airways. Thanks, Rick. Forgot about those. Okay, so back to our question. Doctor sent me to pulmonary rehab. What is that? So pulmonary rehab is a program that local hospitals put on. It's a combination of exercise and education. So typically you'll go for about 6 or 8 weeks. You'll sit in a class 2 days, maybe 3 days a week. You get an hour of education. These are your lungs. This is how you got sick. This is breathing exercises that you can do. These are your inhalers and spacers kind of thing, followed by an hour, maybe an hour and a half of exercise. And it should be monitored exercise. They should be making sure that your saturations stay up, that your blood pressure is okay, that your heart rate is in a safe zone. And in the end of this, I'm going to talk a little bit about an alternative to that. But that's what pulmonary rehab is. And I know that when I was the director of pulmonary rehab program, doctors would refer patients. I would call them and say, would you like to come? And they say, well, what is it? Well, I don't know. I don't want to drag my oxygen tank in public. I don't know if I want to be seen. I don't know if I want to do it. And if I'm able to talk somebody into going to pulmonary rehab, I find that when they surround themselves with like-minded friends, and I'll say like-looking friends, you get in a room of 6 or 8 other people. They're all got oxygen tanks behind them. They all standing there, can't breathe. They're all in the same boat you are. They can only ride the bike for 3 minutes. They can only get on the treadmill for 2 minutes. And the camaraderie that develops really helps everybody. It just lifts everybody up. Everybody kind of spurs each other on and motivates each other to do better, go faster, go farther, and really reap the benefits of what exercise can do for you. So if your doctor referred you, I would say go. Never mind your oxygen tank. Never mind that you don't want to be seen in public. You'll be with people that look and act just like you, and people that are going to help you achieve your exercise goals, because that's the one thing that will get you stronger is doing your exercises. Okay, one more question. I can't walk from my bedroom to my living room without getting short of breath, but my saturations are 93%, but I'm still short of breath. So if I have enough oxygen, what's going on? Why am I so short of breath? And the answer is we need to figure out if your shortness of breath is coming from your lungs or if it's coming from your heart. So if you can't walk from bedroom to living room, for example, and your saturations are good, but you're getting very, very short of breath, we need to find out what's going on. So being short of breath doesn't always mean you need oxygen. There's a lot that goes on in terms of the mechanics of breathing, moving enough air, and then getting that air to cross the lungs into the bloodstream. So maybe there's plenty of oxygen there. Maybe something's going on with the heart. The heart's beating too slow. It's not beating strong enough. So we want to always protect your heart. But if you're not sure, go get seen by somebody and just tell them what's going on. I walk and I'm so short of breath, but my saturations are fine. What's going on? And your doctor will probably order some more tests for you to figure out, what's going on. Rick just chimed in. I hate treadmills, but for other reasons. Treadmill, we'll talk a little bit about treadmills. I had a couple of treadmill questions. In fact, the next one it says, I can walk on a treadmill for 10 minutes easily, but to walk from my house to my car, which only takes 2 minutes, is nearly impossible. What is going on with this? So treadmills are interesting. Treadmills are good in that they get you moving. But what happens on a treadmill, if you think about it, when you're walking on a treadmill, you're on a moving belt. So if you take a step forward on the treadmill, then when you pick up your back leg to put it and take the next step forward, that belt is dragging your front leg back. So the treadmill is essentially doing half the work for you. So for you to walk on flatland, for example, to your car, let's say you're walking, from your condo complex or whatever to your car. So it's a good 2-3 minute walk. And you get really out of breath because nothing's helping you move. You're using every muscle in your legs to get you moving. Whereas you get on a treadmill and you got a belt that's moving the leg for you. So the trick to getting exercise on a treadmill is either at an incline, which don't do this unless you've got somebody watching you and helping you with that, or setting the speed fast enough so that the belt's coming at you faster than you would normally walk. And again, and Rick has chimed in saying, increase the incline. Increasing the incline is fine, but you want to do it in small increments, and you want to check your saturations and make sure that it's not too much. And so the thing that I get from a lot of patients that come in is they come in, they get on the treadmill, they put the incline at 5%, they go 3 minutes and they're done. And they're so proud because you can do a 5% incline, and that's great, but you only went 3 minutes. So endurance is the key here. I would rather have you turn the incline down to 1% to start, and let's work you up to 10 minutes. And then we're going to go to 2% incline. Then we'll go to 3, then we'll go to 4, then we'll go to 5. So it's kind of, you're doing a little both. We're adding speed, we're adding incline. Along with this, we're adding time, and that's what's going to help get you in shape and get your muscles using oxygen more efficiently. So putting an incline definitely will get you into shape. But if you can only do it for 2 minutes, that's not going to help you. We want to go for the long haul here. And it looks like I've got one more question here. It says, some days I feel short of breath all of a sudden. Oh, yeah, we talked about that. Another question in the box. When I wear my pulse oximeter when I walk, the pulse oximeter numbers are all jumpy. They're 88, and then they're 99, and then they're 83, and then they're 99. And what is happening here? So pulse oximeters aren't really made to work well in motion, shall I say. The ones that we have at the hospital are a little bit better because those are made for taking numbers while somebody's moving. But if you're walking with your little finger pulse oximeter, your heart rate is going different. It's picking up the movements. and it kind of gives you a jumble of numbers. So if you stop, you get a reading, but remember, if you stop, now you're in recovery, as we call it. Your heart rate's going to slow down, you're able to catch your breath, so you want to be able to stop just for a minimal amount of time just to make sure that your oxygen is not plummeting. And let's see if I've got any more questions coming in. I think I addressed quite a few of everybody's questions kind of all in one. We talked about in the mechanics of breathing, pulse oximeters, we talked about different drugs. And if you're calling in or you're watching this from another country, I had this question last week. Somebody said, well, we don't have here in, I think they're from New Zealand, we don't have Advair and Spiriva. We have different medications. So your what I call the terols, your albuterol, oldaterol, formoterol, all the terols, those are your beta agonists. So those are, they can be controllers, they can also be relievers. So you want to know, do you have a long-acting beta agonist or do you have a short-acting beta agonist? So the long-acting ones are the ones that are in Advair, for example. Short-acting ones are what is in your ProAir, if you have that, or just your straight albuterol sulfate. And Spiriva is now Tudorsa, I think, and there's also Increase. So that's Spiriva. Again, there's different names for them depending on the country that you're in. So Tudorsa, Spiriva, Increase, those are all the same class of drug. Usually once a day is all you need for that. And another word about your rescue inhalers. If you find that you're taking your rescue inhaler more than twice a day, I call that not really well controlled. It might be that you need a little bit better of a controller regimen. It might be that your rescue inhaler isn't really doing anything. I see a ton of patients who take a puff off their rescue inhaler and cough it right out again. And if that's you, generally what that means is you don't like the propellant that's in that inhaler. Different inhalers made by different companies in different countries have different propellants inside. There's a couple I think that are worse than others, but generally speaking, if that's the case, if you take your inhaler and you cough it right out again, ask for a different brand. You may have to pay a little bit more to get a brand name drug, not a generic, but you're worth it and it'll work a whole lot better. Another thing that happens is maybe you're not using your spacer. Spacers are really, really important to get the drug deep, deep down into your lungs where it will do the most good. So if you're taking your rescue inhaler several times a day without a spacer, it's probably just getting stuck in the back of your throat, getting picked up by the circulation and just making you shake and be all nervous. So that won't help you. Rick is chiming in saying you have to allow time for particle deposition, definitely. You have to not only allow time for the particles to deposit, but you have to allow time for the drug then to be absorbed and work. So even if you get it in the right place, it's going to take a good 10-15 minutes for you to really feel the full effect of that rescue. But again, if you take it and you don't feel anything and an hour later you're taking another puff, you're not feeling any really relief, you're just still kind of wheezy, so an hour later you're taking another puff, then that's not controlled, that's not well-controlled symptoms. So we need to either bump up your control regimen or we need to figure out why the rescue inhaler is not rescuing you the way that it should. So that's all the questions. I'll give a couple minutes for anybody else to chime in with any more questions. But what I wanted to add in is for those of you, most of you who are on this call are on my list. Many of you have seen my blog post on thebreathingspecialist.com. It's www.thebreathingspecialist.com. You can go to the blog posts, and I've got a ton of stuff in there. That's free. Check it out anytime you'd like. If you go on the www.copdsuccess.com, that's where I have my program. Essentially what I did was I took a lot of the pulmonary rehab education points and I put them online into an online learning format. And the reason I did that is because I had so many patients when I was a pulmonary rehab director that I had to turn away from pulmonary rehab because people would say, I can't come, I'm working, I don't drive, nobody can drive me, it's 3 days a week, I can't afford, my copay is going to be $200, and if I do that, multiply that by 16 times, there's just no way. So I saw a void, I saw a need, and I thought I'm just going to fill it. So again, copdsuccess.com. I've got a couple different programs, but check it out. See what you think. I really feel like people benefit from pulmonary rehab, and I just wanted to make it accessible to anybody and everybody. I know I have people that say, well, there's no pulmonary rehab in the country where I live, or there's no pulmonary rehab close to me. The nearest one is 2.5 hours away, and that's a 5-hour drive 3 days a week. I don't want to do that. And Rick brings up another good point. Oh, your inhaler may be close to empty. I see this quite a lot. There's actually a blog post that I wrote about this. So most of the inhalers nowadays come with a counter of some sort. There's a number thingy that tells you how many puffs you have left. If you're using a Respimat, there's a little red arrow on a dial that tells you you're getting close to empty. Once upon a time, we had no way of telling. We used to put them in water to see if they floated or not. We found a lot of patients were pretty much giving them treatments with just propellant and not much medication left. So if you shake your inhalers and feel like there's something in there, there is. It's propellant, and that's why we tell you shake your inhalers really, really good before you go ahead and use them, because you want to mix the propellant with the medication. If you just grab your inhaler and use it, the propellant is what's sitting at the bottom of your inhaler, and when you activate it, you're just getting a propellant treatment. So thanks, Rick, for pointing that out. So shake your inhalers, number one, and make sure that you've got medication left in them. So I've got a billion more things that I could talk about, and that's why I built COPD Success. I've got 24 learning modules in there. Each learning module is about 20 minutes because I don't want to overwhelm anybody, but there's a lot of good stuff in there, just little tips and tricks on using your inhalers and spacers correctly, how to monitor your exercise when you're at home, how do you know you're in the safe zone, what should your heart rate be, what if you're on medications that artificially lower or elevate your heart rate. So tons and tons of stuff in there. Some people have said they like the program. They went through pulmonary rehab years ago and their insurance won't pay for them to go again, but they really want to run back through the program, and they lost their notes or their binder or whatever they got, and they really want a refresher. So you can do that too. So any last questions, type in the questions box. And Rick, anything else you want to add? Something helpful for these folks? All right. Well, thank you everybody for joining. I really appreciate you taking the time to come on. I really hope I see you on the Breathing Specialist blog. You can comment and ask questions there. And I really hope I see you in my COPD Success program. All right. Thanks so much, everybody. Have a wonderful evening. Bye now.